So we're going to talk about pharyngitis. This is a fairly short chapter. We could cover it in about a minute, but I think there are a few things to say. The first article I'll start with, because it is the CDC guideline on pharyngitis in adults. And I got to be the person who chaired the committee that wrote these guidelines. And we came up with, if you read the guidelines, they're very different than the guidelines for pharyngitis in children from the CDC. So I'm going to tell you why, what happened. So 8 years ago, something like that, I got a call asking me to be on this committee that was going to write guidelines for the treatment of upper respiratory infections in adults. And the committee was going to have like 5 or 6 members, and it was going to write these guidelines for URI in general, for sinusitis, for bronchitis, for otitis, and for pharyngitis. And each of us would be assigned to sort of run one of them. And the reason, and so who were the people who were called? Well, I was called because I was an emergency physician. There was somebody who was called who was a family physician. There was an internist who was called. And basically what they tried to, and an ID person, what they tried to do was have representatives of all these different specialties. And the reason they wanted that is because the CDC was concerned at the time that they were treating upper respiratory infection with too many antibiotics. No kidding, right? And they wanted to have buy-in from all these different specialties because they wanted to write guidelines that would change sort of our approach to these diseases, recognize that they're mostly viral, stop using so many antibiotics. How many antibiotics do you think we use for pharyngitis in adults? What percentage of adults who see a doctor for pharyngitis leave with an antibiotic? 85%. It's between 5 and 15% who have strep at any given time, depending upon the season. So it's way, 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 way too much. Of course, it's 60% for a cold, for a URI, which is, sort of nutty. Anyway, so they wanted us to change this whole way of thinking, and they wanted to get everybody to buy in, etc. So we had this panel, and then we had consultants from the ID Society and the CDC to help us along. So the fascinating part was, in my own particular panel, but in all of them, whenever we tried to change the approach, we got enormous resistance, particularly from the ID Society, but also from the CDC. So what they wanted was a sea change in the way we think about this. We would do less tests, give less antibiotics. Every time we suggested anything that would decrease tests or antibiotics, they didn't want to do it. You can't do that. So it was really a strange process. There were many moments where we would have these conference calls where I basically said, okay, you want to do that, find somebody else to do it. And they backed down every time. But it sort of gave me a sense of why the pediatric guidelines may have ended up basically changing nothing. And our guideline changed a lot. I'm going to tell you what it is in a minute. But I think it was mostly because we insisted. We basically said, no, we're not playing if you don't want to make real changes. So here's what we used to do. We used to do zillions and zillions of tests, antigen tests, and throat cultures, and then everybody would go home with an antibiotic. Why would they go home with an antibiotic? Well, let's go back for a second. Why do we care if it's strep? Rheumatic fever. We want to prevent rheumatic fever. That's a really biggie. Rheumatic fever is a tragedy. How many cases of rheumatic fever have you seen? It's basically gone away. There have been a couple of mini little epidemics, hotspots, that lasted very briefly. Nobody knows why. Nobody knows why the strep that you now culture from people's throats, if you do cultures, is not rheumatogenic strep. There used to be these strains that were rheumatogenic. They don't exist anymore in the United States. What makes it really surprising are two things. One is they still exist in Mexico. They exist in other parts of the world, but they don't exist in Western Europe or the United States. It's not like many social diseases where that's totally understandable. Bugs should be able to cross the border, right? There is no homeland security. So I don't understand. That's one thing. The second thing that nobody quite understands is why rheumatic fever disappeared. Because if you think that it had to do with antibiotics, all you have to do is look at the trend of its disappearance. And it started disappearing long before penicillin became into purchase. So the curve looks like this, and we were already down to here before there was penicillin, and down to here before there was widespread antibiotics, and it just kept going down. So it didn't seem like it really had anything to do with our treatment. Okay? Now, if we decrease antibiotics dramatically and it comes back, we'll have to rethink everything we're going to talk about for the next few minutes. But right now, it looks like we don't have this stuff. And in Western Europe, many countries do not even bother with the discussion we're having. They say, who cares if it's strep? And they don't treat it. They don't look, they don't treat it. The only reason to look is if you need to find strep. It's important for us to say this because I think in the United States, we're not at a place where we're going to say, who cares if it's strep? But we should at least know that it's not like finding an MI. Oh, I missed the MI, that's a big deal. You miss a strep, it's who cares? It's not that big a deal. So we'd like to pick up most of them. We don't need a sensitivity of 98%, okay? But why else do you want to treat strep? It helps it get better faster. How much does it help it get better faster? 12 to 24 hours maybe, and that's only if you treat in the first 24 hours. So how many of you want to encourage your patients, everybody who has a sore throat, race to the doctor as soon as you get it, because that's the only way you're going to get benefit from the treatment. By the way, the last article in this chapter, which is the most important, says there are all sorts of other things you can do to make strep feel better, to make sore throats feel better. It doesn't matter whether it's strep or not. And things like gargles and acetaminophen and lozenges. And those things work better than any effect you get from penicillin. And what's more, the only study which compared penicillin versus not penicillin when those things were done found that penicillin offered no symptomatic relief. The only places where penicillin has this marginal symptomatic benefit is when you don't do these other things. If you do them, penicillin adds almost nothing. Nothing, but maybe almost nothing. Okay? So symptomatic relief, hardly a compelling reason to do it. You could do that with just some Tylenol. What else? Placebo effect. So we'll talk about that a little bit later. We have to do something for patients, but you could do that by giving them, oh, you really should take acetaminophen. I'm going to tell you about acetaminophen later, but why it's such a good drug and how you can recoup the placebo effect. We've ruined it sort of because we made it cheap and available. So I have a clue to that we'll talk about in our analgesic talk maybe. What else?
What's happened to post-strep?
Post-strep GN, except that that is not prevented. Never was. There's no evidence that you can prevent post-strep glomerulonephritis. And the last one is to prevent the suppurative complications like mastoiditis and peritonsillar abscess and things like that. And again, it doesn't work. Those things were disappearing before the penicillin era. We don't know why. And if you look at the patients who have them now, and you've all seen cases of these, they're mostly de novo. They're not after they came in with a sore throat. And most of them, they didn't even have a sore throat. So treatment doesn't seem to have much effect on that. So I think it's okay. We want to find strep. We could find strep. And you want to treat it, you could treat it. But it's not like it's a big deal. Okay, that's a really important thing to say. And another thing is you might want to do it for transmission. Okay, so, particularly if you're around a lot of kids, you might want to find it for that reason. Although, again, there's a real problem with that, which is that most of the time, you've already transmitted it by the time you're symptomatic. So that's the background. So we were doing all these cultures and stuff. And by the way, if you're going to give penicillin, you've got to give it early because otherwise you don't get any symptomatic relief. So there are a few articles in here which say, and I'm not going to go through each of the articles, most of them are not really that great, but there are a few articles in here which are interesting, and there's a whole bunch in the literature which say when you do a culture, you got to wait 48 hours to get the results, right? You have to start the penicillin now. Otherwise, why bother? So you start the penicillin now, the culture comes back negative, what do? You never do anything. No one ever calls the patient and say, oh, stop that dangerous medicine. They've already paid for it, they're already on it, they get it. So in fact, the whole culture of doing a culture and giving antibiotics was one that did everything we were trying to avoid. So what we said was, let's stop doing all these things and instead change our whole approach to this. Okay, so one of the big things we had lots and lots of stormy arguments about was doing a throat culture. So let me go back to yesterday's discussion. What's the gold standard for strep pharyngitis? Throat culture. Almost everywhere it's throat culture. Is it a good gold standard? Should it be the gold standard? Lousy gold standard. Why? Lots of false positives. There are lots of carriers. They get a viral sore throat. It's positive. 20% in kids. What about false negatives? Well, there's a bunch of studies which say when you take out somebody's tonsil because they have recurrent pharyngitis, and you grind up the center, you grind up the tonsil and take a core culture, 50% of the core cultures are false negative on surface culture. So when there is strep, you miss it a lot and you overcall it a lot. So what is a better gold standard? Well, probably the best gold standard would be serial ASO titers. Nobody does that. And it would be clinically impossible. Wait 2 weeks to find out whether or not you should have treated them 2 weeks before. So culture is a really bad gold standard. So one of the things we said was no culture. And the CDC guideline in adults, unlike in children, says do not do throat culture unless they're immunosuppressed, you're looking to find a new epidemic, there's concern about rheumatic fever, whatever. Otherwise, don't do it. I had to compromise on that because I wanted to have to make that guideline, but also I wanted to include, I wrote a section, Rochelle Cooper and I, who was my fellow at the time, I recruited her to help me do this, and we wrote a section which said, here's why throat culture stinks, don't do it, don't do it, don't do it. And the compromise was we just said don't do it, but we took out the section which said it stinks. We didn't say why. The paper just says don't do throat culture. But at least I was okay with that compromise. We got the thing we wanted. So the next question was, how will you diagnose strep? If we're going to, it's not that important, but okay, we're going to try to do it. How would you diagnose it? We did say in the paper, by the way, we did mention in Western Europe, some countries don't even care, and that seems like a reasonable strategy. But then we went on to say, okay, how are we going to do it? So what other choices do you have besides culture? Which? You could do clinical, or you could do a strep screen. So how good are each of these? How good? So the first thing is, I can't tell you the answer unless we know what the gold standard is. And the gold standard that's been used to measure clinical exam and strep screen is culture. And it's perfectly conceivable that when they disagree, that for example, when the strep screen says strep and the culture says no, the strep screen might be right. And vice versa as well. So although you're right that the numbers are not that good, they're in the 70% range for both of these, we don't know whether the 30% that's discordant reflects that the others are better. We have no way of knowing. There is no way of knowing. Nevertheless, fortunately, like we just said from the start, this isn't that important a question. So I don't really care that it's off a little bit, and I don't even care that we missed 30%. So what we then went to say was, okay, you have two choices when you treat these patients, when you examine these patients. One is to do it entirely clinically. And there is a guideline called the Centaur criteria. There's also one called McIsaac's. There's a few, but we chose the Centaur because it's the best studied, which we said predicts pretty well. Here's what you have to do. There are 4 criteria for Centaur. You can get a score of 0, 1, 2, 3, or 4. What are they? Tell me. Fever. Fever is 1. Absence of cough, which is really absence of viral symptoms. Okay, what else? Anterior cervical nodes. A lot of people, tender, large anterior cervical nodes, not little shoddy stuff, tender, large, and they got to be anterior. Posterior is typically viral. And the 4th one, exudate. If you have all 4 of them, you have about a 60 to 70% chance of having strep on a culture. Again, who knows whether that's good, but it correlates about 60 to 70%, maybe 70%. If you have 3, you're about 35%. If you have 2, the numbers in here I think are wrong, because I know these numbers pretty well. Unfortunately, the chapter, I don't think they're exactly right. But if you have 2 of them, you're about 10%. If you have 1 of them, you're 2, 3, 5%. If you have none of them, you're 1 or 2% have a positive culture. So we said that's good enough. We didn't think that in this disease it matters all that much. And what we said was one strategy, which is the strategy I use, is do everything clinically. If they have 0, 1, or 2, do not treat. If they have 4, treat. 3, use your judgment. And by the way, rheumatogenic strains of strep tend to be much more symptomatic. They tend to, they made people really sick. So we said, you know what? If you have 3, if the person's really sick, they're really symptomatic, you might want to treat. And if they're not, who cares? You're not going to get any benefit from treating. It's unlikely to be rheumatogenic. So we said, you got 4 or a sick-looking 3, treat them. Everything else, don't treat them. But I had to compromise to have another strategy as well. And the second strategy that's in the paper was 0 or 1, do not treat. 4, treat. 3 or 2, do a strep screen. Now, the reason I don't like a strep screen is not that it's a bad test. It's probably a reasonably good test, but it just adds complexity. And I don't think you need it. But I don't have any problem with it, so we added it. There is an advantage to doing a strep screen, which is the person who really, really, really wants it. To antibiotics, you can say, well, you know what, it's negative. So that's not a bad idea. On the other hand, we absolutely refuse to do what the pediatricians did, which says, do a strep screen, and then follow it up with a culture. Don't do the strep screen, don't trust it. It's like, why would you do that? Anyway, so those are the 2 things that are the official CDC policy. Now, as I said, there were a lot of concern about this, and the ID Society in particular, they bailed from the project. They said, we don't support this. They came up with their own guidelines, which is all cultures and et cetera. And one of the things they said that they didn't like about us was that if we treat all 4s, or you treat even some 3s, I just told you, if you have all 4, you still have a 1/3 or 40% chance of not having the strep. So we're going to be over-treating. And they said, that's really terrible. Instead, do all these tests, and et cetera. But that's not how I look at it. I'll tell you why. If we over-treat 40% of the patients who have 4 out of 4, we're still only over-treating 2% of the population with pharyngitis, because very few patients have 4 out of 4. And in fact, if you use our strategy, you apply it to most populations, you'll be treating about 15% of sore throats, and some of them won't have it, and some will, and we'll miss a few that do have strep by culture. But so what? We'll go from 85% to 15%. We'll treat almost all the people who have strep, and we'll treat all the ones who are sick and have strep. What a deal. Seems to me like a pretty good idea. So this is one of the classic, are we being academic infectious disease guys? The old, I'm sure you all remember, you got somebody coming who was really sick. The first thing you did was tests. Nowadays, we've been taught, right, the first thing you do is treat. And I don't think there's anything academic about doing lots of tests and waiting for the results before you treat. Most of infectious disease now is based on empiric treatment. Just like we said about pneumonia the other day, that it's not based on the culture results, it's based on the environment. What are they likely to have? So, which has been shown over and over and over again to be a much better bullet than testing, not to mention that you don't wait and you don't spend all this money and blah, blah, blah. And it makes it really easy. Go ahead.
Has anybody quantified in the paper the harmful effects of overtreating?
Yes. So what are the harmful effects of overtreating? So there's not one paper, but it's not in your manual, but it's been in manuals that we've done before. Overtreatment, 2 things. One is we tremendously increase resistance. So we have enormous resistance to all sorts of standard medicines in the United States that in places like Scandinavia, where they've stopped doing this, resistance rates have disappeared. So resistance to penicillin, ampicillin, all those drugs in the United States is far, far greater than in Scandinavia, where they...
Can they correlate that to treating pharyngitis?
Not just pharyngitis, all these upper respiratory. The vast majority of what we treat in the United States with antibiotics is upper respiratory infection. So when they stop doing that, you dramatically decrease resistance. The other thing to remember is we're talking about for 12 hours you feel a little bit better, which you could do with acetaminophen, but you get a little bit of, but we forget to mention that 15% of these people get diarrhea. Which would you rather have, a little more sore throat for 12 hours or diarrhea for a week? Not to mention women who get vaginitis as well. So it's not like you're going to kill the person, but of course, this is crazy. So, so that's sort of the summary of this whole thing. Now, the next bit is, so the first thing is, this is what we recommended. This is what your CDC tells you to do. It's still very, the ID people are screaming and fighting, but, that's how it is. Now, the Medicare, unfortunately, in their process measures that we were talking about yesterday, lists doing a strep screen as one of the things, and even, I think, culture is one of it, too, in some form. I don't remember the exact form, but it's listed in there, something about it, which, I think is crazy. Anyway, so my practice, just to tell you, is I treat them all clinically. But I think if you want to be clever and use the strep screen to sort of discourage people, no, you didn't need antibiotics, that's a fine use in that subgroup who really wants it. I wouldn't do it on everybody. The next section in here is about, there's a bunch of papers that are not worth going into, but the next section is about which, there's a little section about do we follow guidelines, and the answer is no. And so whichever one of these guys, somebody wrote a really nice paper recently which went over this big controversy between the ID Society and the CDC, and they said, it doesn't seem to matter because when we measure what doctors do, they don't follow any of them. So, that was one of the other things that I wanted to accomplish with our committee, was to make it simple enough that people would do it. Why not just make it really simple and you can follow it? But part of the problem, of course, is patient expectations, and doctors are very concerned about that. Maybe we'll spend a minute on that. The next little thing is, which antibiotic? It doesn't matter. Come on, you don't need any antibiotic. But the interesting part of it is, if you look at these papers, they all say, we tried antibiotic X, expensive antibiotic X usually, and it was better than penicillin. The reason it was better than penicillin was not because it made the patient feel better, but because we could use it for shorter than 10 days. So what's 10 days of penicillin about? Where'd that come from? How many remember we used to do 10 days of urinary tract infection antibiotics? Or 10 days of pneumonia antibiotics? Where did 10 days come from? Well, it all came from the original studies about strep throat. The original studies about strep throat showed that penicillin you had to give for 10 days, 7 days wasn't good enough. From that, everybody thought you had to treat everything for 10 days. Eventually, they learned you didn't. So 10 days was the standard for penicillin. But, there's always a but. What was the but? The but was 10 days was what you had to do if you wanted to prevent rheumatic fever. It had nothing to do with symptoms. So all these wonderful studies are lies. What they do is they said, we gave 3 days of antibiotic X and the patient got better. But they didn't measure whether it prevented rheumatic fever. They said it's better, penicillin you need 10 days. Yes, you need penicillin 10 days to prevent rheumatic fever. You probably need 10 days of these guys to prevent rheumatic fever. What you don't need 10 days of for any of them is for the patient to feel better. What percentage of human beings on the planet have ever taken 10 days of an antibiotic? How many of you have ever taken 10 days of an antibiotic? There's something wrong with you, sir. So these studies are straw man studies. They say, you don't need 10 days of these. Yes, if you're measuring symptomatic relief, you don't need 10 days. But that was never the reason to use 10 days of penicillin either. So as far as I'm concerned, if you want to treat symptomatically, it doesn't matter what you do. And if you want to treat to prevent rheumatic fever, which there isn't that much reason to do right now, then you got to insist on 10 days, whatever antibiotic you use. And I would recommend you should use penicillin, just regular old Pen-VK. It has the least side effects, it costs nothing. And give them 10 days. And if you really want to insist on 10 days because you're worried about rheumatic fever, give them a shot of benzathine, because that's the only way you're going to get 10 days. right? Nobody's going to do it. So that's the antibiotic question. The last little bit in here, what else is in here? Steroids. We should just mention that there are 4 papers in here. I think we have in the abstracts, we probably have about 10. And what do they show? They're really very unimpressive. If you actually look at these papers, some say marginal benefit, some say nothing at all, no effect at all. So, you know, I know lots of people who say, but I've used it and it really works. And I don't know if we really know that it works, but probably we're fooling ourselves. But if you're going to use steroids, at least restrict it to, first of all, involve the patient. Ask them, do you want it? Something we're really bad at is shared decision making. We should have the patients involved. You know, this steroid might make you psychotic and, you know, and you do bad things. I mean, any of you ever been on steroids for a while? I hate it. Some people like it, but I hated it. It makes me feel like the worst of speeding. It's just awful. Anyway, so steroids is, so ask the patient, and 2, if you're going to consider use it, only in that patient is really, really miserable. Otherwise, come on, the risk, harm benefit is clearly not going to be helpful. In the person who's really miserable, you know, really, really fiery red, you might want to consider it. And the last little bit, again, I'll remind you that the last paper is about non-antibiotic treatment for acute strep throat, and I think it's really good, and it points out that the benefits are much higher than the benefits with antibiotics. The last thing I'll just mention is, what about, I guess we're out of time, I'll just say it really quickly, what about the patient who really wants antibiotics, etc.? You deal with this all the time, right? We always deal with patients who they want something, they don't need it, blah, blah, blah. And we obviously each have to figure out how we deal with that. I believe that if you talk to people in a way where you offer them something and you talk to them rationally, the vast majority, what they really want is your time. In fact, how many of you learned or saw or have ever started out the conversation with, it would be really easy for me to write, but? Well, that's true. It is much easier to write it. What takes time for us is actually talking to patients. There are studies that show that you really wanted satisfaction. It has nothing to do with whether you met their expectations. It has everything to do with whether you spend time with them. And then there's that 1 out of 100 patients who will not take no for an answer to whatever. I mean, I don't fight with them. You know, that's not the patient I'm going to. They want an MRI? No. They want an antibiotic. So be it.